Hi guys, let's discuss the MCQs of the Tricky series part 2. I have posted the MCQs on my Telegram channel, which is Dr.vyshnavi ENT, and this was posted about 2 weeks ago. And now I'm giving you the solution for it. It is a little tricky here, but I'm sure most of you are able to solve these questions. But let's just have a quick look at these MCQs. So, 53-year-old woman undergoes thyroidectomy for papillary thyroid carcinoma, and the surgery is uneventful. But the next day, the patient notices that her voice is weak and she struggles to project it clearly, meaning she's not able to raise the pitch and tone of her voice. So, what is the possible muscle affected, and which nerve is responsible for causation of this? Is your question. They have given very clearly there are no signs of post surgical complications, even hematoma formation. So now we know that whenever we want to raise the pitch and tone of the voice, the muscle that is responsible for doing this is going to be the cricothyroid, which is the tensor of the vocal cord. And since it is a tensor of the vocal cord, it allows us to talk in the pitch and the tone that we normally do. But now, if the patient is having difficulty in raising the pitch and the voice seems weak and the patient is struggling, all of this clearly points us to the possibility of a cricothyroid involvement, and the nerve that supplies the cricothyroid is the superior laryngeal nerve, and this nerve can be damaged during thyroid surgery. So the correct answer for this question is cricothyroid, which adjusts the tension on the vocal cords to change the pitch. Posterior cricoarytenoid is responsible for abduction. It is used for respiration and not for voice. Thyroarytenoid is a adductor. It is not responsible directly to change the pitch of the voice or sound modulation. Lateral cricoarytenoid is also an adductor, but the primary tensor of the vocal cord is the cricothyroid muscle, and which is why that's your answer. Now let's go to the second question, where we have a 15-year-old boy who is presenting to you with proptosis of the eyes and bleeding from the nose. So whenever we have a male patient, we have a bleeding patient, and we have proptosis, the first thing that should strike to you is a juvenile nasopharyngeal angiofibroma. Now, the question to you is, which of the following is not a classification system used in JNA? So in JNA staging, the commonly used classification system is called as the Redkowski's classification. We have modified classification, which is called as the Fish classification and the Sessions classification. What we do not use for JNA is the TNM classification, and hence that will be your answer. So the correct answer to this question is TNM, because all the other three are used. And this is very important because in the previous year's papers, we have seen Redkowski's and Fish classification already a part of the options that were given. So remember the three names, at least: Redkowski's, Sessions, and Fish classification. Then we have got a next question where we have a 34-year-old man who's presenting to you with a progressive submandibular swelling with trismus dysphagia and drooling. And this is worsening with a dental pain. The patient is leaning forward with his arms on the knees and is also struggling to breathe. His voice is muffled, and examination reveals to you that the tongue is elevated and there is induration in the floor of the mouth. And despite oxygen supplementation, his saturation is 88%. So, whenever we think of a submandibular swelling after a dental treatment or associated with a dental pain, associated with hypoxia, the first thing that should strike to our brain is going to be Ludwig's angina. What is Ludwig's angina? Ludwig's angina is nothing but the cellulitis of the submandibular space. So this submandibular space is further subdivided into two spaces, a sublingual space and a submylohyoid space. Now, whenever the sublingual space is edematous, it pushes the tongue upwards and backwards and compromises the airway, making endotracheal intubation difficult. So can I do rapid sequence intubation with neuromuscular blockade? No, that's not possible. Can we do a fiber optic intubation with topical anesthesia? No, because again, the tongue is blocking the upper airway. So even if you go from nose, it's not possible. Can you do a surgical tracheostomy or a cricothyrotomy in local anesthesia? Yes. So here the question is, which is the least appropriate management for this patient? So these two are definite managements, which is cricothyrotomy in case of complete obstruction, surgical tracheostomy if you need it when cricothyrotomy is not working. Now we're left with two options which we have to decide as the least, because both of them you won't do. But what is the least one you will do? Of course, awake fiber optic you can do because the patient is awake. You can negotiate. You can ask the patient to push the tongue outwards, or ask the patient to protrude the tongue, and you can negotiate, put a small size tube. And since the patient is awake, you're trying to maneuver the airway, it can still be possible. But once you give a neuromuscular blockade, and if you cannot intubate, the patient will collapse on table. So the least appropriate will be a rapid sequence intubation. So this is your right answer. Even though A is the closest option, you should know how to rule out A from C. Now let's go to the next question, where we have a 31-year-old pregnant woman who presents to you with progressive bilateral hearing loss, worse in the right ear, and difficulty in hearing whispers. Her mother had similar symptoms, and the patient underwent surgery for hearing restoration. Rinne's test shows bone conduction greater than air conduction in the right ear, and audiometry reveals an airborne gap of 20 decibels. So, which of the following tests is least likely to be associated with the suspected diagnosis? We know our diagnosis very clearly here is nothing but your otosclerosis. So, for otosclerosis, are we going to see Gerhardt's notch on audiometry? Yes, that is commonly performed test. Do we see an AS type of tympanogram? Yes. Do we see a Schwartz sign on otoscopic examination? Yes. So all of these are commonly used tests and commonly seen findings. What we don't see commonly is a perilymph fistula test positive and perilymph leakage. So your answer, which is the least likely, is going to be option D. Let's go to the next question. A child with bilateral conductive hearing loss is accompanied with an external ear abnormality. Rinne's test shows bone conduction greater than air conduction in both the ears, and Weber lateralized to right ear. So this all indicates external and middle ear abnormality. So whenever Rinne is negative, it is conductive hearing loss. Conductive means external or middle ear abnormality. So which of the following embryological structure plays the least significant role in development of this condition? So whenever we talk of external ear or middle ear, the pinna comes from the mesoderm of the first arch. Then we have got the external auditory canal, which comes from the ectoderm of the first pharyngeal arch. Then we have the middle ear, which comes from the pouch of the first and the second arch. So we know first arch, second arch, and the first pouch and the second pouch are responsible somewhere or the other for formation of the external ear and the middle ear structures. What is not responsible at all to give rise to an external ear or a middle ear structure is the otic placode, because otic placode gives rise to inner ear. And if there is an otic placode abnormality, there will be an inner ear abnormality, and the patient will have sensory neural hearing loss. So with this, they're asking you which structure is least significant. Your answer has to be otic placode. Next, we have another question where we have a 3-year-old boy who's brought to the emergency department one day after a history of sore throat, fever, and difficulty in breathing. The child is fully vaccinated, including H influenza B. On examination, the child is anxious, sitting upright with the neck extended, mouth open, drooling, and refusing to lie down. He makes high-pitched noises during breathing, especially on expiration, and attempt to examine his throat only worsens his distress. So we are talking about what condition? We are talking about acute epiglottitis. We're talking about acute epiglottitis, sudden onset, fever, drooling of saliva, tripod position, and high pitched noise, which is inspiratory stridor. All of that prompts to you for epiglottitis. So, in acute epiglottitis, do you want to lie the child flat and establish an intravenous line immediately? You preferably will not try to do this because flat will again obstruct the airway more. Number two, when you're trying to put a IV line, the child will cry, move, and that can again cause increase in airway obstruction. Do you want to attach monitors and induce anesthesia and inhalational agent in the ER itself, keeping the child seated? Yes, this seems to be an appropriate answer, but let's go through the other options as well. Perform direct laryngoscopy in the emergency department to assess airway patency. Never. This is contraindicated in acute epiglottitis, so you will not do this. Do you want to transfer the child to the OR operating room, monitor the child, induce anesthesia while seated using oxygen and inhalational agent? Yes. This is what you should do. Of course, emergency room is also a great place, but when you're in an operating room, you have equipment available, you'll have anesthetist available, you'll have surgeon available. In case you want to do a cricothyrotomy, in case you want to convert to a tracheostomy, you have everything available there. So operating room is a safer place than the emergency if we have a child with acute epiglottitis. B and D are the closest answers, but once you take the child to ER, to the operating room, you're going to monitor the vitals. Now you're going to keep the child seated itself, and you're going to give oxygen via the mouth and sevoflurane or any inhalational agent that will put the child to sleep. And then you're going to secure the airway by intubation. If that's not possible, you're going to do a tracheostomy. So the more safer environment will be an operating room, considering the need for tracheostomy and cricothyrotomy. So you will choose this over B. Although B is not a completely wrong answer, between the two, if you had to choose, you would choose D. And that is why I say this is tricky series. You will have to find the trick. Okay, let's go to the next question where we have a 2-month-old infant who has noisy breathing that worsens with feeding, crying, and lying supine. He has no surgical history. The child is gaining the weight well and shows clear nasal passages without any craniofacial abnormalities. Chest examination is normal, but inspiratory stridor is heard on auscultation. So, what is the gold standard for diagnosing? What is our diagnosis here? 2-month inspiratory stridor, increases on feeding, crying, and in supine position. We know our answer is nothing but laryngomalacia. Laryngomalacia is the most common congenital anomaly of the larynx, and here we would see an omega shaped epiglottis. How would we see an omega shaped epiglottis? By fluoroscopy? No. By doing a bronchoscopy and a DL-scopy, of course, that can be done, but why would you do a bronchoscopy for an laryngomalacia where you just want to view the epiglottis? No. Fiber optic laryngoscopy, best because it is soft, small, and easily you can visualize through the fiber optic scope. Radiological imaging studies can be done, but of course, when we have clinical picture available, that is more conclusive in our diagnosis, which is why answer is going to be flexible fiber optic laryngoscopy. Let's go to the next question, where we have a 2-year-old boy who's presenting to the hospital due to a weak cry, and there is a lesion in the anterior 2/3 of the left vocal cord, and the patient undergoes a surgical removal. Histopathology shows hyperplastic stratified squamous epithelium with a central fibrovascular core, which is suggestive to you of papillomatosis. And papillomatosis in a juvenile age group or a child suggests to you of juvenile onset recurrent respiratory papillomatosis. So, which viral strains is most commonly responsible for causing this condition? Juvenile onset recurrent respiratory papillomatosis is most commonly caused by HPV 6 and 11. 16 and 18 are also responsible, but less likely for your respiratory ones. Let's go to the next question, where we have a 3-month-old child who's having weak cry, stridor, and feeding difficulty. The child is having inspiratory stridor and nasal regurgitation during feeding. There is bilateral immobility of the vocal cord. So, whenever we have a bilateral vocal cord palsy in a pediatric age group, congenital vocal cord palsy is what you should suspect. And we've learned that congenital vocal cord palsy is associated with Arnold-Chiari malformation. So this is what you're going to take in your answer. Congenital laryngomalacia is not the answer because you would see omega-shaped epiglottis and not immobility of the vocal cord. Neonatal myasthenia gravis can be a possibility, but since here there is a clear relation between Arnold-Chiari and vocal cord palsy, we are going to take this as our answer, even though myasthenia gravis could be a close possibility. Usually, it will be seen at birth when the mother to child there will be transmission, and Here, we are not going to see this at 3 months of age, so we are going to rule out myasthenia gravis. Subglottic stenosis would present to you with a biphasic stridor and not an inspiratory stridor. And we know there is a direct correlate or an association between congenital vocal cord palsy and Arnold-Chiari malformation. They exist. There is an entity that exists. So we are going to take this as the right answer. So let's go to the last question, where we have a 4-year-old child who develops sudden respiratory distress and high-pitched stridor while playing. And his parents report that he was eating small pieces of food before the symptoms began. The child is gasping for air but is still able to cough. Very, very important thing. Whenever there's a foreign body in the airway and if the child is still able to cough, what will be your initial management? Whenever there's a foreign body in airway, we've always learned we have to do a Heimlich's maneuver. But if the child is unable to cough, you do a Heimlich's maneuver. If the child is able to cough, you will encourage the child to continue coughing. If the child can't cough and becomes apneic, or the child is having fallen saturations, then you do a Heimlich's maneuver. Then you can do a blind sweep maneuver, and you can try to do a laryngoscopy to remove the foreign body. That is, when there is complete obstruction, you will do a direct laryngoscopy. But if there's a partial obstruction, you're going to do a Heimlich's maneuver or a blind sweep maneuver. And in these two situations, the patient will not be able to cough. If the patient is able to cough, you will encourage the patient to cough to get the foreign body out. So, with this, I finish my tricky series part 2, and I hope it was helpful for all of you. If you have any questions, please do feel free to write down in the comment section below. I have my Telegram channel, which is Dr.vyshnavi ENT. You can join in there and you will be able to access all the tests that I give there. I do give regular tests on almost weekly basis, so you can join in the Telegram channel to get more information. Take care and thank you.